Ladies and gentlemen, thank you for standing by, and welcome to the COVID-19 media briefing conference call. At this time, all participants' lines are in a listen-only mode. After the speaker's presentation, there will be a question-and-answer session. To ask a question during the session, you will need to press star 1 on your telephone keypad. Please be advised that today's conference is being recorded. If you require any further assistance, please press star 0. I would now like to hand the conference over to your speaker today, Mr. Mike Schomer. Sir,
Thank you for joining us for the COVID-19 daily media call for May 6th. Governor Walz is not on today's call. Our agenda will start with an update on the COVID-19 outbreak from Minnesota Commissioner of Health Jan Malcolm and from MDH Infectious Disease Director Kris Ehresmann. Following that, we will be hearing from Minnesota Department of Administration Commissioner Alice Roberts-Davis on some of the preparedness work she's been leading. Following Commissioner Roberts-Davis, we will open it up for media questions. With that, I will now turn it over to Commissioner Malcolm.
Thank you, Mike. Good afternoon, everyone. The global total as of this morning was nearly 3.7 million cases and 258,000 deaths. In the United States, we are reporting slightly more than 1.2 million cases and 71,000 deaths. I will note for those of you who follow the Johns Hopkins site that there was a note this morning that these numbers haven't changed much because they hadn't received updated data from New York. So in case you're wondering about the relatively static numbers there, that's the reason as we understand it. In Minnesota, we have a new total of 8,579 cases, up more than 700 from yesterday. So as we've been discussing these numbers as we are testing more, and particularly as we are testing in the communities with significant outbreaks going on, we are seeing what we're expecting to see there. In terms of the testing volume, just to repeat what we had said in prior days, we had a technical glitch over the last couple of days. So the large number of tests processed or counted as processed yesterday, almost 5,000, included about 2,000 from the day prior. That issue has been resolved, but you will continue to see that what appears to be this odd spike up and down for the last couple of days. Unfortunately, we are reporting another 30 deaths among Minnesotans from COVID-19. 24 of these deaths occurred in residents of long-term care facilities. The demographics remain similar. 22 of the deaths are in Hennepin County, 2 in Anoka, 2 in Ramsey, and 1 each in Mahnomen, Nobles, Stearns, and Dakota counties. This includes 7 people in their 90s, 15 in their 80s, 6 in their 70s, 1 in their 60s, and 1 in their 50s. There are currently 443 patients in the hospital, 180 of them in intensive care. We will be reporting increasingly in future days on the racial and ethnic breakdown of some of these cases, both the cases, hospitalizations, and death statistics, as I have mentioned on prior calls, and I think Kris has as well. We're very aware of the disproportionate impact of the disease on populations of color and American Indians, as well as those suffering from underlying health conditions. And we think it's just going to be important going forward to break down these data in a more granular way. I would also like to acknowledge that today is the kickoff of National Nurses Week. Especially now, every day, but especially now, we want to recognize the important work of nurses across Minnesota. Certainly our nurses who work in hospitals and clinics, but also nurses working in settings like long-term care who are also putting themselves at risk to protect some of our most vulnerable during this pandemic. And I want to mention school nurses whose dedication to students and families is ever vigilant, especially in these unusual and trying times. With that, I am going to turn it over to Director Ehresmann for additional comments, and then we'll open for questions later after Commissioner Roberts-Davis. Kris.
Thank you, Commissioner. And I want to acknowledge that we are continuing to see, as the Commissioner said, our case numbers rise. We definitely have been seeing cases that are associated with processing plants and manufacturing, so want to acknowledge that that is part of the increase that we're seeing, as she mentioned. And then I'd like to shift to a topic that I historically speak about more than I have in the last months, and that is talking about the importance of both well child visits and keeping up to date with vaccination. We know that with all of the changes in our lives due to COVID-19, that our regular routines are definitely disrupted. But we are recognizing that we're seeing our immunization rates fall, and we know that that is a marker for children getting in for well child visits. And well child visits are so very important, not just because it's an opportunity for children to get their needed vaccines, but because there are many other screening tests that are done at that time that are really important to evaluate a child's development as well as exposure to things like lead. So I just want to make sure that we're reminding parents that even as you're dealing with this new normal, that it's really important that you reach out to your healthcare provider and make sure that your child is continuing to get their well child visits and keep up to date with their necessary vaccination. And with that relatively back to normal message, I will turn it over to Commissioner Alice Roberts-Davis.
Thank you, Director Ehresmann. Good afternoon. I'm Alice Roberts-Davis, Commissioner of Department of Administration and lead for the Critical Care Supplies Work Group. So as a reminder, Governor Walz established the Critical Care Supplies Work Group in mid-March to source the personal protective equipment, or PPE, needed for our frontline healthcare workers. This work is an interagency team of state procurement professionals, project managers, data analysts, the Minnesota National Guard, and supply and logistics specialists. In the past several weeks, we've stood up a critical care supplies warehouse. We started at zero, and over the past several weeks, we've purchased, processed donations, and received several federal stockpile shipments totaling millions of pieces of PPE. That data can be tracked on the COVID-19 dashboard. I think it's important for us to note that hospitals and other healthcare providers are and should be maintaining their existing supply chains for PPE. The Critical Care Supply Warehouse is intended to be a supplement to PPE purchased by hospitals to support their COVID response. The state warehouse supplies hospitals and other healthcare operations with PPE when their supplies reach 4 to 7 days. We had previously replenished at 0 to 3 days, but we've been able to loosen the replenishment time frame because of the amount of PPE in our warehouse. This strategy allows for the disbursement of critical supplies while it still ensures that the state is maintaining adequate inventory for the expected peak periods. Additionally, the state warehouse supplied cloth masks to long-term care facility staff, and we supply additional PPE when there's a suspected case of COVID or a positive COVID test on site. The warehouse averages between 30 and 40 shipments each day, and those go to care providers around the state. So let me say a little bit more about the race to get PPE and where we are now. First, the stay-at-home order bought us valuable time to get these supplies, and we're appreciative for that. When the Critical Care Supply Work Group started in mid-March, there was a tremendous amount of uncertainty about whether traditional suppliers would be able to get us the PPE, much less the volume that we needed, which is millions and millions of items. So that's where our work began. We started working on our traditional supply chains with our vendors. We were working the phones with suppliers around the world. I have to say that at 3, 4, and 5 o'clock in the morning when other parts of the world are wide awake, so was our team. They were up making calls and vetting leads for product that could come to our state. We've also been incredibly fortunate to have the public-private partnership that was highlighted previously by Governor Walz and led by Ecolab CEO Doug Baker and his team. That's been truly beneficial for us. But most helpful in that relationship has been their assistance in sourcing products and transportation for those goods to the state of Minnesota, and even their ability to vet vendors and assist us in testing samples to ensure that the PPE that we're purchasing is going to meet standards. This really saves our team a lot of valuable time, and it saves taxpayer dollars as we're not purchasing items that are not going to meet our specifications. The situation today is still fluid. It's still a very competitive marketplace. We continue to see spikes in pricing for goods, and freight costs are volatile, but we have gained a tiny bit of breathing room to monitor those changes and make decisions based on cost and risk at this point. We are more consistently getting face masks, face shields, and medical gloves. Medical gowns and N95 respirators have been a little bit more challenging, but particularly with the N95, we're really cautious about making purchases that we can be certain will meet hospital specifications. We've started to see some stabilization in the marketplace for hospitals as well, and they seem to be getting supplies through their normal supply chains at this point in time. Our current usage rates are allowing us to have about a 1 to 3 month supply of most PPE, except for gowns, as I mentioned earlier. That's between both the hospital and the state warehouse. But as peak approaches, the burn rate for these supplies will increase, and we want to be sure that we have ample supplies on hand. So just as an illustration of usage rates, current averages of the statewide hospital usage per item over the past 10 days, not including long-term facilities or other critical care facilities, is about 9,000 face shields a day, about 877,000 gloves, 37,000 gowns, 93,000 masks, and 11,000 N95 respirators each day. So again, this is why the public health mitigation measures that Governor Walz has taken are critical. They're buying us the time that we need and the healthcare providers time that they need to get these supplies to ensure that they have them. We've made significant progress, but we do realize that we have a lot of work to do, and we will continue on this journey. With that, I will turn it back to Mike Schomer.
Thank you, Commissioner. We'll open it up for questions now, and as we do, we'll ask that reporters limit their questions to one primary and one on-topic follow-up. And also that we limit the number of questions from each media outlet so we can get to as many as possible. With that, operator, we are ready to take questions.
Thank you, Mr. Schomer. As a reminder, everyone, if you wish to ask a question, please press star and the number 1 on your telephone keypad. To withdraw your question, please press the pound key. Please stand by while we compile the Q&A roster. Your first question comes from the line of CEO Keith from Box 9. Mr. Keith, your line is open. You may ask your question.
Hello, my question is for Health Commissioner Malcolm. Approximately 2 weeks ago on April 24th, Assistant Commissioner Huff said that 400 to 500 contact tracers would be needed with the increase of testing. Today, Assistant Commissioner Kelly said that 4,200 contact tracers would be needed, which is approximately 10 times the number from just 2 weeks ago. I'm wondering why the dramatic increase in contact tracers, and this is important, of course, because the House is now considering a bill to fund a contact tracing program.
Well, thank you. Absolutely, the numbers have increased significantly from our prior estimates. I think partly as we have learned more about the effect of asymptomatic spread and therefore the need to test more broadly beyond symptomatic-only patients, the interest that employers are showing in increased testing and increased surveillance, increased health screening for their employees and potentially customers, and what we are seeing in the food processing outbreaks and in long-term care, all of which has sensitized us to the need to be prepared when indicated to test more broadly than simply testing symptomatic people, as had been our priority and our focus earlier in the outbreak. So that has driven a lot of the numbers, and I think also just learning from other states as they are ramping up the kind of numbers that they're looking at. There have been various studies and various ranges that you may have heard about. Some suggesting, ratios of one contact tracer to every 100 cases down to 1 to every 10. So again, it's as with many things, there are wide ranges of estimates of what would be needed. We're updating our forecast based on, as I said, just more experience with the kinds of outbreaks we're seeing and our desire to be more inclusive in our testing approach.
Thank you. One follow-up, because Assistant Commissioner Kelly said at the outset the attempt was to start an investigation within 24 hours. And now, because of the increase in positive cases, you're not getting to the investigation within 24 hours. She did not say how long it's actually taking, so I'll ask you, how long is it taking to do this, the case investigations right now?
I'm going to ask Kris Ehresmann to help answer that question, but I think just the sheer volume of what's going on now is causing us to think about new ways to augment our traditional approach. Usually we don't really begin the contact tracing until the disease investigation is completed, and that's a very thorough and careful process that Kris can comment on. And then the contact tracing starts, and we're thinking about changing up that order so that we can begin to get to contact the contacts, quicker, sooner than might be called for just if we were relying on the completed investigations alone. But Kris, can you speak to both the complexity and the time it takes to do the investigations?
Certainly. So in terms of the time it takes to do the investigations, yes, we had been doing all of our follow-up within 24 hours of receiving a report, and that has slowed in part because of the volume and in part because it's taking longer to do our contact investigations, because vast majority of our cases now are English is not their first language, so we are having to either use interpreters. We do have bilingual staff, and we're also using the language line so that people can hear our messages in the language that they are most comfortable. And so that has added to the time that it takes to actually complete the investigations. And the investigations are very thorough, and we go through with the individual, about their symptoms, onset, their activities, potential contacts, and then there's a lot of time spent answering questions. People have a lot of questions when we're contacting them, and so we spend a lot of time on that. Hopefully that helps answer your question.
Operator, I think we're ready for the next question.
Yes, sir. Your next question comes from the line of Greta Powell from MinPost. Ms. Greta, your line is open. You may ask your question. Ms. Greta Powell, your line is open. You may ask.
Yeah, my question, sorry about the
Go ahead,
my question is about serology testing. We're getting a lot of questions from people who wonder if they can get a serology test or when they might be able to get a serology test. I'm wondering if MDH has guidelines for clinics that are giving these out, or if there are guidelines from Mayo and the U. And also I'm wondering if there's a state plan to track the numbers of serology tests. I understand last week MDH told me that they weren't tracking the numbers, but I'm wondering if there's a plan for that.
I will ask Kris to answer that as well, but we had a call just this morning with our health system partners and Mayo and the U on that very topic. There's, as I think we've talked about in prior calls, just a vast array of serology tests that have suddenly hit the market that are of unknown or not very robust results. Or certainty in the sensitivity and the specificity of the results of the test. So we want to make sure that we're using serology testing well and where the evidence really supports it. And that, as I've said before, that's why we're particularly excited about the research partnership with the U and Mayo, because they're at the leading edge of figuring out when serology testing is helpful. And we will be getting out some guidance to our healthcare partners on that subject in the very near future. That said, I know there is serology testing going on in the community, and we ourselves are working on how to use that for estimating prevalence in the population. Kris?
Thank you, Commissioner. Yes, definitely there is a lot of serology testing that's available, but as the Commissioner indicated, much of it is not FDA approved, and so the quality is dubious. We do have some information on our website just about things to consider related to serology testing and the limitations, as we've talked about. Right now there are some really important elements that we're missing related to serology testing. One is what level of antibody, because serology testing looks at the antibodies that you produce having had infection with COVID. So what level of antibody indicates that you have protection? And then the other question is, how long does that protection last? And so before we can use that tool for individuals, we need to know more about those two elements. It can be a very useful tool for looking at population prevalence and giving us an idea of what has been happening in the population in terms of infection. But when it comes down to providing an individual patient with guidance about their health status, health history, we need more information. And in terms of are we collecting that? The case definition for COVID-19 does include serology as part of the definition, so it can be reported to us, but because, as we've talked about, there are gaps in terms of what it means, we're not doing anything with that data right now. So we'll be working with partners on this going forward so that when we do look at the information, we can interpret it appropriately and accurately as to what it means for us.
Your next question comes from the line of Bill Werner from Minnesota News. Mr. Werner, your line is open. You may ask your question.
Okay, thank you. And thank you. Commissioner Malcolm, this one is for you. I'm sure you're in receipt of the letter from Senator Housley. And the context of it is that at this point, 80% of Minnesota's COVID-19 fatalities are residents of long-term care facilities. She says in her letter, quote, "In New York, officials expect long-term care residents to account for approximately half of all COVID-19 fatalities, where many long-term care facilities did not receive adequate state assistance with personal protective equipment, testing, and staffing. In Florida, where residents of long-term care facilities account for only 30% of the state's total COVID-19 fatalities, the state government acted early to implement clear guidance for facilities and deploy the National Guard to assist with facility cleaning, staffing, and testing, etc." So my question is, why is Minnesota, at least according to these statistics, appear to be doing significantly worse than New York and Florida? And the second part of that question is, how soon can we expect a fresh initiative from the Walz administration to address this particular situation?
Well, thanks, Bill. The first thing I would say is I think there's been a lot of good coverage in recent days about the importance of this issue and this population nationwide. And folks have drilled in on the fact that the data are very unclear at this point. There is no national official count as of this point about long-term care prevalence. And it's notable, I think, that it was just last week that the Centers for Medicare and Medicaid directed skilled nursing facilities to report cases and deaths to the CDC. But note, they only require reporting from skilled nursing facilities. And we don't know this for sure, but we think it's quite possible that many of the states are only reporting nursing home or skilled nursing facility data. We have a much broader inclusion of what we consider to be long-term care, assisted living facilities, group homes, adult foster care, mental health and substance abuse treatment centers, and the like. So I do not think we're looking at apples to apples comparisons when we're looking at Minnesota data versus other states. That said, that is in no way meaning to suggest that we don't think this is a serious issue and a serious opportunity for improvement. We've been working hard on this since the beginning of the epidemic. Kris has talked about the fact that we started testing more aggressively the 1st of April, after we saw the first confirmed cases in long-term care facilities at the end of March. We've been testing for it, we've been looking for it, and we've been finding it. And we've been, I think, pretty thorough in our capture of the cases and the deaths that are attributable to COVID. There again, it could be that some states are reporting, case reports are different, and Kris can comment more on that, whether things are being reported as pneumonia rather than COVID, et cetera. So there's a lot of digging to do to get good numbers, and we agree that that's critical. In terms of kind of the next iteration or the new initiative, as you referred to it, I think the governor has been clear that he has asked for exactly that, an assessment of what we've learned over the last 6 to 8 weeks and what we're going to do additionally based on that learning. And we're working on that right now, and you can expect to see further initiatives from the administration over the next literally couple of days.
Thank you, Commissioner.
Your next question comes from the line of Matt Sepik from Minnesota Public Radio News. Mr. Sepik, your line is open. You may ask your question.
Hi there. This is for Commissioner Malcolm or for Kris. We noticed that Clay County seems to have a mushrooming number of cases, 215 there and 14 deaths. What's going on there? Is this another situation with a lot of long-term care cases or something else?
Kris, can you take that one?
Sure. Actually, what we're seeing in Clay County includes both long-term care, so congregate care, as well as some congregate living situations where we're seeing cases. So that would include homeless shelters, that type of thing. So two situations in which we have settings where what's happening in the community when it's introduced into those settings gets amplified. So that's what's driving the increase in cases in that area.
Okay, and I had a follow-up too. We also noticed that there's been a sudden jump in the number of people recovered, even as total cases have increased. What accounts for that? And this is statewide.
Yep, that was also just catching up some data. So we had a number of people that we recovered. I mean, recovered is not the term we want to use. I'm sorry, and that is a problem. I want to say the number of individuals who have been released from isolation, that we recently had a jump in that because we were able to do additional follow-up with people and get that data in. But I want to be clear that does not mean recovered. That means that they've been released from isolation.
Gotcha. Thank you.
Your next question comes from the line of Tom Hauser from KSTP TV. Mr. Hauser, your line is open. You may ask your question.
Thank you, and thank you, Commissioner and Director Ehresmann. A question again about long-term care. Do you have a figure of the 488 people who have ended up in ICU, what percentage of those cases are people who were brought to the hospital from long-term care? And so I'm wondering if you have a percentage of those people from ICU and the percentage of total hospitalizations.
Kris, do you happen to have that data? I do not.
As you're asking it, I'm thinking, I know that we got that for someone, and I was just trying to remember who it was for so I could search for the email. I don't have that off the top of my head, but we'll get that back to you.
Because I think, Kris, you had said last week that there are a number of people who come from long-term care to the hospital, but you didn't have the exact number. My follow-up question to that is, once they I don't know what the number is that survive ICU, but where do they go if they recover from long-term care? Do they go back to their nursing home, or is there another place they go where they have to be quarantined for a while, or how does that process work?
We're currently working on, alternate care sites that could be places for people to go as an intermediary between acute care and returning to long-term care. But at this point, individuals would go back to their home, which is the facility where they were residing, and we would make sure, the goal is that they would be non-infectious, or that the facility would have the capacity to care for them if they were being transferred during a period where they were still infectious. And by that, I mean that they would have the necessary personal protective equipment and things like that to be able to care for care for a patient safely.
Is that risky to put them back in a home after they've had COVID-19, even though they've been in the hospital and presumably recovered? Would an intermediary place be better?
Certainly an intermediary is a good option, but it's important to keep in mind that these individuals, we're looking at whether or not they have finished their infectious period, so that's one consideration, and if they have not, then that the facility has the capacity to care for them safely, which would be a single room, all the appropriate personal protective equipment, all of those things.
Last thing from the Commissioner, any update on when a model will be available? You had said maybe middle of this week.
Yes, I have not heard yet whether we've got all the peer review comments back, but I think that we're planning, and I apologize, I don't know when. I know we're intending to do another media briefing as we did before, and I don't know whether that will be this week. I know I'm expecting to be able to see the data by the end of the week. We'll get you a specific schedule for when the briefing will be.
All right. Thank you both.
The next question comes from the line of Paul Scott from Forum News Survey. Mr. Scott, your line is open. Please ask your question.
Hi, thank you. I wanted to go back to this issue of hiring more contact tracers. 4,200 lines up with the Wuhan fleet. I know that they had reportedly had 9,000 contact tracers for a city of 11 million. We have 5.5 million Minnesotans, which puts us right at that point, 4,500. Was it always the case where we needed thousands of contact tracers?
I think, as I mentioned in the prior question, that our estimates of that have really changed and been informed by all that we've learned in the last 6 weeks or so, and continue to learn literally week by week about asymptomatic spread and symptoms that hadn't previously been thought to be associated with COVID, which are popping up as new considerations. So as the universe kind of broadens of people that we'd like to test, that means obviously an increase in resources necessary to do the follow-up as well. So the numbers have certainly grown, and we're intending to do that in a variety of ways. Kris can comment on the amount of staff that have been added just in recent weeks and are coming on next week and the week after that. We're working to increase the involvement of our local public health colleagues in the process of investigation and especially contact tracing. They are extremely well positioned to do that work in the context of their local communities. So that's been a priority, is getting local public health in a position to play a lead role here and supporting them from MDH, but really having them much more hands-on. And then other strategies that other states are looking at, relying on a volunteer workforce from the health community or from other parts of the community that are interested and willing to help. So we're kind of looking in a lot of different directions to be able to reach those numbers in a very short amount of time.
Do you anticipate this to be a workforce, that'll be with us for a long time? You're expecting, several surges. Is this a long-term investment?
I think that really goes to the value of a model that can scale up and scale down as needed. So we're looking at that and talking with our legislative leaders about that as well. Kris, did you want to make a comment?
Oh, I was just going to say that as of Monday, we had 150 case investigators. We're adding another 160 this week. And when you talked about the model that was used in Wuhan, yes, even when we were starting with our initial, would we need 750 case and contact tracers, that was based on what Massachusetts was seeing, but we had the data from Wuhan, which was much needed. You needed many, many more case investigators and contact tracers. So we started with Massachusetts thinking that might be more of what Minnesota was seeing, but have continued to adjust, as the commissioner said, because of what we're seeing in terms of the increased testing. So even when we started our poor attempt at estimating what we might need, we had information about Wuhan as well, but started with Massachusetts thinking it might be more in line with what we needed, and we have modified it as time has gone on and as we've learned more.
Thanks so much.
The next question comes from the line of Tim Nelson from MTR News. Mr. Nelson, your line is open. Please ask your question.
Hi, thanks for taking my call. We're seeing some pretty significant jumps up in Stearns County, up nearly 20% today. I don't know how much that's affected by the catch-up in the data. What's going on up there in terms of testing and contact tracing to slow the community transmission up there, especially the 2 poultry plants? And is there any particular focus on the Somali community up there?
I'll ask Kris to address that specifically, but just want to take this opportunity to really thank and call out the really proactive leadership of Centricare and Stearns County Public Health, who have just been really, really on it and really proactive about increasing the availability of testing and really acting on it quickly. So, and I know there is a significant amount of work going on with the Somali population and others up there. Kris, can you add some more?
Yes, so definitely there has been a lot of testing that's being done. As the commissioner indicated, Centricare has been coordinating that, and the increase in testing is related to what has been happening in the plants that we've seen, cases associated with those workplaces. We had a call Monday evening. The governor's office coordinated with local public health as well as community leaders and state agencies, and talked about, the outreach that we could continue to do with the community, including the Somali community. So there has been conversations and work being done to make sure that we're reaching out to all the communities who are affected and employed in these industries.
Thank you.
Your next question comes from the line of Brandon Stahl from Pier 11. Mr. Stahl, you may ask your question. Your line is open.
Hi. So we've been taking a look at per capita death data in Minnesota compared to other states, and Minnesota's rising compared to other states and also has more deaths from COVID per capita than any other neighboring state. And I'm wondering what you attribute this to.
Well, I think, and I'll invite Kris to chime in as well. I do think, as we've touched on in previous questions, that the thoroughness with which we're attempting to investigate and test and identify cases in long-term care is a part of that answer. And in terms of the the rates comparing to other states. I think it's partly due to that, partly due to the simultaneous outbreaks in several of our rural communities, which, if you're looking at, I too have been tracking reports of how much more quickly we're growing on a percentage basis, which is both a factor of the concentrated cases that are happening in some of these communities, and the fact that we started from a comparatively modest or moderate growth rate. So percentage-wise, week over week, we have indeed had very significant bump ups. Kris, would you like to add anything?
Sure. As we talked about earlier, starting on April 1st, and in a time when we had limited testing capacity, we put our energy into making sure that we were identifying cases quickly and early in our long-term care settings. And as a result of that, we have identified COVID in the most vulnerable populations who over time may be more likely to count as a death case than other populations. If we had not put our energies into focusing on this population and said that we were going to focus on, say, a workforce and, normally healthy workers, it would be a very different picture. So I want to acknowledge that we have really focused on this population. They are the population that is most likely to have complications and to die from COVID. And so as a result, we do have a higher death rate, and it is in our elderly populations. We are not seeing deaths in younger populations at the rate that we are in this population.
What would the rate of testing have to do with the rate of deaths?
If we had not been identifying cases in this population, we wouldn't be identifying the deaths as COVID deaths. So if we had only been testing school-age children in Minnesota, we would say that, we haven't seen any deaths in that population. And our death rate per capita would be very low based on the population that we were testing. We have not had a homogeneous testing program across the state. We've because of the need to focus our testing on those individuals for whom intervention is most critical, we have emphasized our testing and made sure our testing was for the most vulnerable individuals, and as a result, we don't have a picture of the entire population. So it's not as if we tested, everyone that lived in Minneapolis, and that we had the results of all those people, and that our rates then were based on a full population. We have been selectively, if you will, testing in the most vulnerable populations, and as a result of that, selective testing. And again, it's selective because we wanted to intervene, but because of that selective testing, then that is going to have an impact on outcomes, because these are the most vulnerable people. So if we had had the ability to test everyone in a population across the age range, you would have a much better picture of true rates. So this is selective testing, and as a result, I don't think that it's representative of our entire population.
Operator, we have time for one more question.
Noted, sir. Your next question comes from the line of Lauren Lehman. The question is withdrawn. Your next question comes from the line of Dave Orick from Pioneer Press. Mr. Orick, you may ask your question.
Thank you. Kris, I'm not sure if you quite understood Brandon's question, the last one. He was talking about per capita deaths, not per case, per positive case deaths. And so your explanation would make sense, but only if you're saying that other states are underreporting deaths in long-term care. And Commissioner Malcolm sort of suggested that earlier. Are you suggesting that that's what's going on?
Yes, I can tell you that in looking at some of the guidance for testing in other states, they have not had the same predominant focus on long-term care that we have had. They have looked at hospitalized patients, they have looked at individuals who are symptomatic, and we made long-term care our highest priority. And for a number of weeks, that was almost exclusively where we were seeing cases identified.
Okay,
so
thank you.
I think hopefully that was clear, and I think that is what we were suggesting earlier. Again, because of this particular illness and how similar it is to other respiratory illnesses, influenza-like illnesses, flu, pneumonia. It's not that hard to imagine that if you weren't looking for COVID, a lot of those cases, and bearing in mind that there are a very large number of deaths every day, every week in long-term care facilities due to a whole range of causes. That the question of how similar or not similar, dissimilar are the case definitions and the amount of testing for COVID as opposed to any of a range of other quite common illnesses.
Okay, thank you. And related to that, you just began reporting probable deaths from COVID, and I'm wondering how that you think might play into completing our picture versus other states, as well as determining, if you know yet, whether Minnesota has experienced any excess deaths, because the CDC numbers suggest at one point we might have a very moderate amount last month, but not recently.
Kris, can you take that?
Yeah, Dave, can you restate that? I know we started reporting probable deaths, and those are those deaths that are reported on death certificates, but do not have a laboratory-confirmed COVID test to accompany them. So that is based on the clinician's judgment. And so they are, I guess, pulled out separately or acknowledged separately. But the last part of your question about CDC and...
Yeah, excess deaths. I'm sorry if I was jumbling a bunch of things together. What do you know about any excess deaths in Minnesota? Have we had them yet? Do you think looking at the probable death count will help determine whether we have or not?
You mean excess deaths from COVID or excess deaths? I know that that's used for influenza, and we look at, what we're seeing in terms of, are we at an epidemic threshold for cases or other things? So I'm afraid I'm not fully understanding what you're asking. So perhaps I can get back to you on that after the call.
Well, I think I may be able to help. The Yale School of Public Health is looking at excess deaths around the country. The New York Times has examined them across the globe, and you can't exclusively tie them to COVID, but there are definitely clear patterns that when COVID outbreaks increase, you see a higher number of excess deaths that are not accounted for in the official COVID counts, and so it's suggesting an undercount of COVID cases. It sounds like in Minnesota, though, you think we've got a really pretty good handle on the COVID counts because we've been focused on testing the most vulnerable. So I'm just wondering, but maybe you have more information on that.
Okay. Thank you. Thank you for explaining that for me. Yes, I feel that at this point we have a really good handle on what's happening related to COVID deaths. And yes, there will certainly be some additional cases or deaths that are reported. But I do think that because we are focusing on our most vulnerable populations, we aren't missing as many deaths as could be the case in other parts of the country.
Thank you, Kris, and thank you. Yeah, thank you, Kris, and thank you to all our speakers for the call today. If any reporters had questions we were not able to get to during the call, please feel free to reach out to our office at 651-201-4989. Have a good day, and we'll talk with you again soon.
Ladies and gentlemen, that concludes our conference for today. Thank you for participating. You may all disconnect. 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 You may all disconnect.